Well, good morning, everyone. This is another edition of PEN, or Pandemic Eye Network. I am your host, Dr. J, coming in from Santa Clara Homestead, Kaiser. Today's topic is something that you guys are all familiar with, and maybe even getting yourself, because as you can see here, I am by myself, which means most of you guys are working from home, lucky you. And during this shelter in place, I'm sure you guys have all been baking and making your own bread and pasta, even making your own boba, which you haven't shared with me. Well, good thing I can't drink and eat that right now. But if I did, I would probably join you guys since we are talking about, yes, diabetic retinopathy. And before you're quick to judge me, I've seen all you guys start eating your candy when you do your diabetic photos. So we are all guilty of pretty much making fun of our patients. But this is a quick review that we'll go over. You guys are well versed in all these things, but it's good just to do it, and also because I have no choice. So, what is diabetic retinopathy? Well, people with diabetes, of course, have a increased glucose level, and with increased glucose in the blood, it causes vessel damage. And especially with fine vessels that are located in our eye, these leakage of blood and fluids can cause swelling as well as new vessel formation in the retina, which unfortunately can cause vision loss. What are some symptoms of DR? Blurred vision, of course, floaters, distortion, central field loss, especially when we're talking about macular edema. It can also affect poor night vision and even impairment of color vision. Some signs of DR: MAs, dot blot hemorrhages, flame-shaped retinal edema and heart exudates, cotton-wool spots, venous loops and beading, ERMA, and macular edema. And we'll go over some of these in detail. So with microaneurysms, these are the earliest clinical signs of diabetic retinopathy. These occur secondary to capillary wall outpouching due to parasite loss, and these appear as small red dots in the superficial retinal layers. Moving on to dot blot hemorrhages, these are very similar to MAs if they are small, so it's sometimes hard to differentiate. These occur as these microaneurysms actually rupture in the deeper layers of the retina, such as the inner nuclear and outer plexiform layers. With the flame-shaped hemorrhages, which are commonly found in hypertensive retinopathy as well, these are splinter hemorrhages that occur in the more superficial nerve fiber layer. With exudates, these are caused by the breakdown of the blood-retinal barrier. This unfortunately leaks proteins, lipids, and other types of fluids into the retina, which has its characteristic yellow appearance here. With cotton-wool spots, these are actually nerve fiber layer infarctions when these precapillary arterioles are occluded. These are actually frequently bordered by the MAs, so these light up as those fluffy, white infarcts. With the venous loops and beading, this for me personally I always find hard to find. They occur adjacent to non-perfusion and causes the structure to change in these veins. These reflect increasing retinal ischemia, and this is actually the one sign that is the most significant predictor of progression to proliferative diabetic retinopathy. So, although these are very hard to spot, definitely keep an eye out for them, because that's your number one reason to check on these patients to make sure they don't progress to PDR. ERMAs also can be difficult to spot and distinguish between neovascularization. These ERMAs are remodeled capillary beds that are found usually on the border of non-perfused retina, so keep an eye on those as well. And of course, macular edema. Sometimes it's very hard to spot, sometimes just with a photo or even under the slit lamp. Many times, of course, with the OCT or a FA, it's easily diagnosed, but just with looking at it through a 2D image will be hard to spot. What are some risk factors of DR? Of course, uncontrolled blood sugar and high HbA1c can lead to DR. Other systemic diseases like hypertension and hyperlipidemia can lead you down this path as well. Being pregnant, that of course is gestational diabetes. Being a smoker will increase the risk. The length of having diabetes mellitus can increase your risk of DR, which later in my favorite topic, statistics, we will talk about that. And being African American Hispanic as well seems to be a higher risk factor. So two types of diabetic retinopathy, non-proliferative and proliferative. With the non-proliferative, we have three types that we talk about: mild, moderate, and severe. With mild, if there's at least one microaneurysm, we characterize it as mild. With moderate, if we see more than 10 MAs or hemes, or even just one exudate or cotton wool spot, we'll label that as a moderate. And with our severe, we follow the 4-2-1 rule, where if we see 4 quadrants of MAs or hemes, either 2 quadrants of venous beating and or 1 quadrant of IRMA, we will label that patient as having severe NPDR. Now with PDR, there's a lot of things we can see in the retina. Neovascularization, preretinal hemorrhages, vitreous hemorrhage, fibrovascular tissue proliferation, tractional retinal detachment, and macular edema, which we clinically define as retinal thickening 500 micrometers or less from the center of the foveal vascular zone, hard exudates 500 micrometers or less from the center of the FAS, or retinal thickening 1 disc diameter or larger within 1 disc diameter of the FAS. And just to go over some pretty pictures of these signs in the eye. Neovascularization, hallmark of PDR. You see this, you pretty much send to ophthalmology immediately. That pretty much that they have PDR. With the preretinal hemorrhage, this is the classic boat-shaped hemorrhaging in the eye. This appears as pockets of blood within the space between the retina and the posterior hyaloid face. And as blood pools between the space, it has this kind of cool boat pattern. With the vitreous hemorrhage, this may appear as a diffuse haze. So sometimes it's hard to even know that there's blood in the retina, but if you see some type of haze that in the vitreous, that could be the vitreous hemorrhage, or you can see this characteristic kind of blood clumping within the gel of the vitreous. With fibrovascular proliferation, this is usually seen associated with the neovascular complex. It may appear avascular when the vessels have already regressed, but it kind of shows as this white tissue that proliferates throughout the retina. And unfortunately, this can lead to tractional retinal detachment. Usually appears tented up, immobile, and concave. So look out for these as well. Now with some of us with the diabetic program, we're part of the ACT-DR, which is me, Sylvia, and Izzy. Just quickly go over kind of what we do when you guys send over your moderate to severe NPDR patients. So pretty much our job as ACT-DR is to triage. You want to kind of filter out the patients who are high risk of macular edema or those who we just monitor to make sure they never develop macular edema or vision loss. We draw these circles that are 3 millimeter and 6 millimeter from the center of the macula to kind of give us a baseline to see if there's any risk as well as progression over time. We really focus on exudates. That's what ophthalmology tells us to look at as the main source of the risk level, whether they will have will have macular edema or not. If we see any exudates that are within any of these two circles, we would order a macular OCT to rule out CME, pretty much. If these exudates or cotton wool spots are found outside the circles, then we actually will have these patients come back in 6 months for a 5-field and just make sure that these exudates are not progressing or getting close to these circles, which is close to the macula. With these OCTs, when we review the results, if we see any cyst or fluid within 1.5 millimeters of the fovea, or if we see the central 1 millimeter thickness show that it's over 320 micrometers, then we would refer to ophthalmology for possible treatment. If there's no central fluid or thickness, or the fluid is outside the central area, it's in the outer areas of the fovea, then we would just have them come back in 4 months, repeat the OCT, and pretty much every 4 months just track their progress, make sure this fluid isn't inching closer to the central macula. So some workups for diabetic retinopathy. Labs, of course, is the main thing the primary care doctors do, checking their fasting glucose, making sure they keep it under 108. HbA1c, make sure we keep it at under 6%. FAs, of course, can give us a lot of good detail on any leakage in the eye. MAs will appear as pinpoint hyperfluorescent lesions in early phase, and then in later phases you actually will see leakage out of those vessels. With dot blot hemes, these are opposite. You will see them as hypofluorescent. IRMA presents as collateral vessels that do not leak, and then of course with NEO it will light up like a Christmas tree, so that's very obvious to see under FA. With OCT, as we just talked about, this is a way we manage CSME. A great way to see if there's retinal thickening or swelling or fluid in the retina. And of course, we can even see things with a vitreous like vitreomacular traction. B-scan, we can use it if there's any type of vitreous hemorrhage blocking our view. We can just check the status of the retina and make sure it's not detached or anything like that. Some treatments for DR. Not really treatment, but with glucose control, that's our first way to hopefully prevent, the need for treatment or progression. A really cool stat is a 1% reduction in HbA1c actually reduces the risk of retinopathy by 31%, which is quite significant. So I'm sure that's why PCPs push glucose control so heavily, because we don't want to even go towards retinopathy. And with this stat, that's quite a bit of a reduction. VEGF inhibitors are go-to as well, just like with macular degeneration. Same drugs as before, Eylea, Lucentis, Avastin. Typically better than laser photo coag, just because we're not, burning off retina. But they still do laser, for either focal laser or PRP, depending on the case. And of course, if all else fails, vitrectomy and even cryotherapy. So to end, my favorite topic, again, statistics. Some fun facts, fun for us, not fun for the patient, unfortunately. 16 million Americans have diabetes mellitus, but 50% are actually unaware they have it, which is very scary. So definitely when you see your patients and they haven't had a routine wellness checkup or haven't seen their PCP in a long time, make sure you encourage them to at least get blood work done or screen for diabetes, since again half don't even know they have it. Of those who know they have diabetes, only half receive eye care even. So many of these patients may not even know they have retinopathy until it's pretty severe and have vision loss. So again, great at Kaiser where we're trying to get everyone to the diabetic program and at least take some pictures, if not have a routine eye exam. At least we can catch these patients and hopefully treat them accordingly as soon as possible. This is the leading cause of new blindness between the ages of 25 and 74 in the US, which accounts for 12% of all blindness in the US. So this is definitely a disease that affects a wide range of life, especially in the prime of our lives where we're working and we need to make money and we have families. So very unfortunate if blindness can be caused during this stage of our life. So we have a huge responsibility to prevent our patients from even getting close to being blind from this disease. As I mentioned before, one of the symptoms or I guess risk factors of DM was how long you had the disease. Here, if you're type 1, usually the first 5 years of the disease, rare to find clinically significant DR. However, after about 10 to 15 years with this disease, about a fourth to half start developing DR. And then after 15 years, almost 3/4 to 100% of these patients actually develop clinically significant retinopathy. So if you track of when they were diagnosed with type 1, make sure you are very, look at them very closely and make sure you look for any signs of DR. With type 2, not as bad, but, still pretty high as you go along. About 11 to 13 years after being diagnosed, about a fourth get NPDR. After about 14 to 16 years, about 40%. And then after 16 years, about 60%. And finally, just some stats about more serious signs of, severe NPDR and PDR. About 700,000 Americans actually have PDR, which is an annual incidence of 65,000 patients a year. And also 500,000 Americans have CSME, which is an annual incidence of 75,000. So quite a bit of people have more advanced diabetic retinopathy. So here are my references. Again, thank you for listening. Hopefully this was a good review. If you guys didn't hear, yesterday on the 29th of April, Santa Clara County's health inspector announced that routine eye care actually is now essential. So, which is great news. Hopefully we can start seeing patients soon again, of course safely and slowly. But hopefully these videos from me and Ashley can kind of remind you guys about the stuff we see with patients. I know it's been a long time for a lot of you guys. And I miss you guys, and hopefully I see you guys soon in clinic. And remember, be there or be rhombus.